And good morning, afternoon, evening to all our participants, and welcome to this first session today. My name is Priya Balasubramaniam. I'm a public health scientist with the Public Health Foundation of India, and I also co-direct the Center for Sustainable Health Innovations at NUS Singapore. So welcome again. And this first session is on reshaping health systems capacity and service delivery, and the first part of our mutual learning tri-series on unlocking private enterprise for public good, redesigning health systems during COVID-19 and beyond. So the focus of today's roundtables, as you are all aware, will be new partnership models for the delivery of health services and health technology. So thank you all once again for accepting our invitation and being here today. For those of you who are still joining, we would need you to please ask anyone who's joined via telephone to identify themselves so that Vinay and Shabina, you can see their names on the screen, can rename them to allow all participants to see who they are. And Vinay and Shabina will unmute each caller as they go to them. And hopefully we don't have too many folks on the phone today. So before I go on, a brief outline of what our agenda is today. So we will start with a brief overview presented by myself and colleagues, which will be followed by a tone-setting panel discussion moderated by my colleague Desta Leko from Amref Health Africa. Following this, you will be moved to one of 3 70-minute roundtable sessions. You will be automatically moved to your breakout rooms, which have been pre-assigned to you with a very short countdown. At the end of our breakouts, we will all reconvene to a short concluding plenary session where key points from each breakout will be shared along with next steps. So this is going to be the structure of our agenda today. And we are really looking forward for a very exciting set of discussions over the next hour or two. So on with it. I would like to actually begin by introducing us as organizers. We are part of a group called the Private Sector in Health Thematic Working Group. We're part of a larger organizational body called Health Systems Global, which has over 5,000 members from academia, research, as well as the development sector. And we, as a network of health systems researchers, have really spent a lot of time trying to better understand the nuances and the diversity of private sector actors, especially in mixed health systems. Some of our work involves contributing to new kinds of thinking about the performance of mixed health systems, building new partnerships for research and learning, and of course, having meetings like this or platforms like this by which we can generate and share evidence with you all. So what's the point of convening this and inviting you all here? So this is a first in a short series of 3 meetings that focus on health systems capacity and service delivery. The next meeting will focus on the governance of the private sector and mixed health system. And the last one, of course, will be around the role of evidence. The objective of this is really to generate fresh ideas on how private health service delivery and access can actually engage researchers like ourselves to partner more effectively with them, along with governments, and public health mechanisms across populations and levels of care. What's the outcome that we're hoping to achieve? What we're really seeking is to create a collaborative platform for shared value creation and alignment between the private sector and the government in being able to identify health priorities for interventions as well as mutual engagement in order to strengthen country health systems. And why? So I think the primary agenda is to make mixed health systems perform well, COVID-19 is changing the health sector landscape even as we see it, and has exposed many fault lines in country health systems. There are a variety and a diversity of private sector providers in terms of ownership and relationship to their governments as well as regulatory systems. And of course, there's a need to ensure access to affordable mix of preventive and curative services, and also reduce the risk of dangerous or exploitative practices. So our objective is to better understand all this. And yet we find that there is very little clarity on the various mechanisms of engagement between the private sector and the state, or even among themselves, especially in situations like the pandemics that we're facing now, and also in terms of long-term relationships in the future. I will stop here, and I'd like to introduce my colleague, Dr. Jerry Bloom from the Institute of Development Studies, Sussex, who will talk to you a little bit about the how. Over to you, Jerry. Jerry, you will need to unmute yourself. You will need to unmute yourself.
Yes, thank you. Anyway, it's very good to meet you all. I suggest we're in a period of major transformations in health systems. And this will involve really a redefinition of the roles and responsibilities of government, of private actors, and of civil society. And all of this is happening in a context of very rapid technological change. This means that governments will need to build capacity to provide leadership, but also private actors and citizens groups will need to develop the capacity to take on new roles. The bad news is there's no blueprint, no off-the-shelf design for what this transformed health system, how it should be organized, and what it should look like. There's a need for experimentation and learning. And that's really what we are initiating in this meeting and the ones to follow. So we brought together leading thinkers in government, in the private health sector, in bilateral and multilateral organizations and research institutes. First, to look at what's happening during this response to COVID, which is putting so much pressure on health systems, and look at when innovations have been emerging. Then, what can we learn from what's happening now for the transformation of health systems and the strengthening of health systems after COVID? And finally, what are strategies for effective collaboration for a learning approach to health system change? We need to get to the next slide. This is the first of a series of meetings, and I hope for a longer process of engagement. On July 29th, as Priya said, there'll be a meeting on governance and accountability. In August, we'll have a third meeting to agree the way forward. Who can say what it will be, but we anticipate that some people participating in this meeting will already develop some ideas for improving health system performance at national or regional levels, and may well be telling us about what they've already started to do. Secondly, we'll be developing an agenda for future research and for new kinds of partnerships for learning. And finally, we can be much clearer on the kind of platform that would be useful to enable ongoing mutual learning between different stakeholders and also between countries and regions. So I look forward to the discussions.
Thank you, Jerry. I'd also like to now invite our colleague, Dr. Fadi El-Jardali. He's a board member of Health Systems Global and is with the American University of Beirut. And Fadi will now link what we're doing now as a group of researchers from institutions in the global South and North to Health System Global's broader agenda, which is one of the largest biannual convenings, the Health Systems Research Conference 2020, which is happening later this year. Over to you, Fadi.
Thank you, Priya. Thank you, Jerry. You've done a fantastic job of the introduction. So as Priya mentioned, I'm a board member of the Health System Global. I just wanted to actually speak for 1 or 2 minutes. So Health System Global is actually a global membership association institution that is really combined researchers, policymakers, and decision makers and implementers who are really dedicating to improving health systems and policy research. So Health System Global has a number of thematic working groups, including the private sector in health thematic work group, which we are really quite privileged and honored to actually partner with this group and support this conference. How this work will feed into the symposium. As you know, the Health System Global Society we do a symposium, global symposium, every 2 years, and this year will be in November. So in November 2020, it will be partly virtual, but also there will be a face-to-face also engagement later in March 2021, and this is because of the COVID-19 reality. So I just wanted to mention that, in fact, there is a lot of intersection points between what will be discussed in this conference and the theme and the sub-themes of the symposium. As you know, that the general theme of the symposium for 2020 will be reimagining health systems for better health and social justice. Now, certainly when we put this theme, we didn't have COVID at that time, but we realized that in fact the theme very well fit the COVID-19 world now. So we have 3 sub-themes. One of them is really engaging political forces. Second, engaging with social, economic, and environmental forces. And third, engaging technological data and social innovation. So this really this conference will help really, as Jerry and Priya mentioned, that will advance thinking on the role of the private sector with more of a bolder, I would say, exploration of the alignment, of the leveraging, of the regulation of the private sector when it comes for better future health system. We believe there will be really quite a lot of cross-cutting areas that will be really engaging, whether it's really the new way of engagement with the private sector, the new type of partnership with the private sector and different actors, rethinking the political economy of the private sector in health, how we can really try to better engage the private sector in disease prevention, pandemic responses, etc. But more importantly, how we can accelerate the emergence of technological innovation, integrating those type of innovation and partnership as part of the health system arrangement and health system delivery. So a lot of excitement about how this conference will link and align with the discussion we're going to have in November as part of the global symposium, as well as the policy meeting that will be conducted in March 2021, as well to actually more of distill out the key messages and the way forward. So as Jerry and Priya mentioned, I will finish by saying that we believe that this conference, with the several sessions that we will have will further agenda for better understanding, documenting the different aspects and role of the private sector in redesigning health system. Particularly now, many countries are thinking about redesigning health systems as a result of Corona. Help create a robust research agenda on the role of private sector in building future health system, and hopefully looking at a new type of partnership, networks, and more of an interface with different private sector actors in the redesign and the reimagining of health systems for the future. We're very much excited about this conference, and we're looking forward for the sessions. Thank you so much.
Thank you very much, Fadi. It is now my great pleasure to invite my colleague, Desta Leko from Amref Health Africa, who will both moderate and formally introduce the speakers of our keynote tone-setting panel. As they say, all important dialogues begin with a macro perspective, and we're really excited with what we're going to hear now from this very eminent panel that we have today. Over to you, Desta.
Thank you so much, Priya. You were cutting off a little bit. I hope everyone heard what she said. Very, very excited to be here. Again, I'm Desta Leko. I'm the Global Partnership Director at Amref Health Africa at the headquarters. I'm also a member of the Thematic Working Group for Private Sector for Health Systems Global, and co-organizer of this virtual knowledge exchange series. Today, we're honored to have with us an esteemed group of experts to help set the tone for the first of our 3-part session. on unlocking private enterprise for public good. That's what we're focused on today. Each of our guests brings a unique perspective to the topic at hand and will help us set the tone and frame the discussions which will continue in the breakout sessions. They are policy shapers and influencers and leaders within their respective settings. And our speakers will consider, of course, as they respond to the questions I'll put forth, the unique position that the COVID pandemic has placed us all in and the impact it's had on private sector engagement and partnerships during this certainly unprecedented time, and in fact beyond COVID as well. So it's my pleasure to introduce you to Honorable Dr. Vinod Paul. Dr. Paul is from the National Institute of Transforming India, Government of India, Niti Aayog. He was appointed as a member there in August 2017, where he leads the health and nutrition verticals. He's played a pivotal role in formulating the Poshan Abhiyan and the Ashman Bharat initiative. I hope I said that correctly, Dr. Paul. And prior to being appointed as member of Niti Aayog, Dr. Paul has been a member of the faculty at the All India Institute of Medical Sciences in New Delhi for over 32 years and heads the Department of Pediatrics for nearly a decade. Our next speaker is Dr. Stefan Swartling Petersen. Dr. Petersen was a professor of global health. He's currently Associate Director, Program Division of Chief of Health at UNICEF. He was a professor of global health at Uppsala University and at the Global Health Division of Karolinska Institute of Sweden. He's also been a visiting professor at Makerere University in Uganda, and as a health system researcher and medical doctor, he's done extensive fieldwork in Tanzania and Uganda and worked with different ministries of health and organizations such as WHO. Dr. Githinji Gitahi, our next speaker, whom I know well, has joined AMREF. He is the group CEO at AMREF Health Africa, the largest health development INGO in Africa. Dr. Gitahi joined AMREF as the Group Chief Executive Officer in June 2015. He's a passionate advocate of pro-poor universal health coverage, and he serves as the co-chair of UHC 2030. I'm sure you'll hear some of that passion today in his discussion. He's held senior leadership roles over the past 20 years with Avenue Group, Madison Insurance, GlaxoSmithKline, Nation Media Group, Smile Train International, and of course AMREF. He's a medical doctor and also holds an MBA. And then I'll come to Ms. Jayashri Iyer. Dr. Iyer is the Executive Director of Access to Medicine Foundation and directs the foundation strategy, its stakeholder dialogues and research programs. And as a spokesperson, she is actually actively involved in stimulating change within the pharma industry. She joined in 2013 to build up its in-house research expertise. And I'm sure many of you are familiar with the document that comes out of the Access to Medicine, which many in the pharma industry look forward to receiving. She's worked at the interface of the global health community and the pharmaceutical industry for 12 years. Before joining the foundation, Jayasri was responsible for creating, negotiating, and managing public-private partnerships in research and development for infectious diseases and oncology. Welcome to all of you. I want to also acknowledge and welcome Honorable Dr. Mishra Swarup Ranjan Kiprop. And I have been asked to call him Dr. Kiprop, which makes it very, very much easier than I would imagine. Dr. Kiprop is a member of parliament in Kenya, in Eldoret County. He is a physician by training and has been instrumental in leading UHC within the county and the country as well. And we are very, very much pleased to have Dr. Kiprop here to also share, maybe lend a little bit of his thoughts on the subject matter. So without any further delay, I would like to engage with our first speaker. And I will direct some questions at the panelists and hope that you also just keep in mind that we're looking at, private sector engagement, current pressure on health systems, what can we learn, strategies for collaboration. So let me start with Dr. Paul. Dr. Paul, I'm not sure I see you on my screen. Are you with us? Can you unmute yourself if you're here? Dr. Paul?
Desta, perhaps while
Is Dr. Paul
Paul
with us,
makes
or
it to the,
Yeah.
maybe we can start with the next speaker. He's probably, he's supposed to be coming from one
Okay,
building
great.
to another.
Perfect. So we'll go to Dr. Peterson. Great. Dr. Peterson, are you with us? Can you just unmute? Dr. Peterson, as a health system researcher, you've been vocal on the impact of blanket lockdowns on the ability for children and women to access essential health services during this pandemic. And we know and we recognize that this is a setback that has substantial costs, not just to the health system, but also human costs. And more recently, you published research on the disproportionate impact of COVID on ethnic minorities. And so I'd like to just ask you, what's the challenge, the key challenge you see to childhood health from COVID pandemic and the associated economic downturn? And of course, which aspects of private sector can contribute to addressing this challenge? Dr. Peterson.
Hi, Desta, thanks. And great to see so many people on board. I think as we all have seen, whether we see it in the field, some of you, or whether we see it in the papers, modeling from Johns Hopkins and others, it's the so-called collateral effects of COVID and the battle against COVID, which become the primary effects for MNCH, for women and children. And we see projections of actually increased mortality for the first time in many, many years, to the tune of hundreds of thousands of under fives and tens of thousands of women. And that comes from a combination of effects, including the economic downturn, as you've said. But if we today look at the service utilization aspects, I think what we've seen is that people are in lockdowns, many times unable actually to effectively slow down the virus for lack of food or soap and water, but certainly unable to or hindered to seek care because of the lockdown in many countries. They may be scared to seek care for fear of being contaminated and catching the virus. And on the provision side, we can see health workers who are actually scared for themselves, scared of providing services for lack of information or lack of protective equipment. And then finally, health services may actually be diverted. So that actually points to the fact that people are much more on their own. And I would assume, but again, this is where we don't have the evidence, and it's great to be with researchers, that private service providers around the corner who sell 50 shillings worth of tablets, if you go to them after lockdown or during lockdown or in the few hours in the day when it's open, chances are they have become more important service providers for women's and children's needs in the community. But again, these are assumptions and guesses, because I must say I've been disappointed at how little we've been able to tell from HMIS, Health Management Information Systems, in real time about decreases in service provision, for instance. So I think there's a huge risk to MNCH and effective utilization of quality care. And I would think and suspect, but again, I'm looking for evidence from all of you as to what extent this has actually changed care-seeking patterns towards more private sector service delivery. And I would say that finally, in this round, Esther, that I think we've also in COVID seen a first phase, which in many countries have been very hospital-centric. And it's time that we actually now start looking for a second wave or a second phase, which actually comes back to engaging communities and engaging primary healthcare and primary caregivers at the community level. So I think there's a huge agenda there where private service providers will be important. Over.
Thank you so much, Dr. Peterson, and you've raised a couple of good points. And I think actually, as you were closing your comments, you talked about the second waves and the need to engage private sector and private care providers and also engage at the community level. So that actually is a really great segue. And Gitinji, Dr. Gitai, I know that you are very much a proponent of, pro-poor support to the community level. and you've been engaging not just at the national level, but also local level, and really collaborating across different stakeholders. So maybe I can ask you to, and I'm going to just veer a bit away, but just to speak a little bit to the issue of, in some countries, in Africa, certainly we have not reached the peak yet, but in some countries now they've reached the peak, coming down and coming up again, as we see in countries like the US, etc. When we talk about that second wave and the need to engage private sector for primary care, and also involve community and do it from the community basis, perhaps you can just comment on that briefly, Githinji, and maybe even discuss briefly, what are some effective strategies for building collaborations between government and the private sector to improve access to care?
Thank you, Desta. Yeah, I think I'm unmuted. Yes, thank you very, very much. And thank you, Peterson, for making your remarks so brief so that you can allow me to make mine longer. So I'll, I'll eat into your saved time. But I would like first to maybe look at what we are talking about. I think the conversation about private sector, and I'll come to your question, Desta, is also a bit marred by what definition. So when people think about private sector, depending on who you're speaking to, they may have a different lens of who you're talking about, who is private sector. If you talk to people generally in the SDG framework, sustainable development, they add together private sector, consumptive private sector that affect health, and therefore the discussion of the role of private sector can be really big. If you say now you also want to talk about social determinants of health, and therefore talk about the role of private sector as a social determinant of health, all the issues around NCDs. So for this conversation, and for my own input, I would like to just say that we are dealing with a private sector that is in health-related products and services. And that also forms what we call the private sector constituency of UHC 2030. We look at private sector that is within a related health-related products and services. The other thing I would like to say is that when we talk about private sector, we are talking about a multiplicity of dimensions. We are talking about both formal and informal private sector, which Dr. Peterson has talked about, which are related in service delivery, products and all that. We are talking about for-profit and not for-profit. I think there has also been the conversation around private sector being for-profit. I think organizations like ours, like Amref Health Africa, can also be classified within private sector, though we also play another role as a third sector. But there is a debate, even we've had at UHC 2030, about should faith-based organizations who are providing private services across countries be classified as private sector and therefore form part of the private sector constituency of UHC 2030, or should they be classified as civil society and classified into the civil society engagement mechanism? There is a lot of lack of clarity around there, and I think that is also part of the challenge. And the final one is obviously we are talking about both local and international. So that is the framework within which I'm going to make my remarks. Now, back to COVID, you've reflected on this, and I don't want to go through statistics. Everyone here has a lot of access to data on COVID and the epic curve and whatever is happening in countries. Everyone has become a new COVID epidemiologist. So there is absolutely no need in referring to data and how it's changing. The things I would like to reflect on are what are the roles and what have I seen as the roles of private sector in this context. One is services and products. Now, when COVID came, we saw there was a lot of challenges with supply chain. There were challenges to access PPEs. There were challenges to access test kits, and private sector came in to fill that gap very rapidly and quickly. I can't tell you the number of conversations that we had in the national task forces about which private sector company to call, how we can accelerate accessibility of test kits. And the reason we African governments have closed the gap of tests is because of collaboration with the private sector, where private sector worked closely with WHO and governments to ensure products were accessible, not only for test kits, but also for PPEs and other things that were needed for this response. Remember also that in services, in some countries like South Africa, when we talk about their testing capacity, the last data I looked at, maybe it's changed. A significant part of it, actually almost 50% of the tests were actually done in the private sector. So therefore, it was a total collaboration. And I'm seeing in other countries, private sector clamoring to be included in the testing capacity of governments. Some governments are still insisting, no, this is only the governments that are allowed to do this. And of course, there are some challenges. I saw Ghana, I was listening to the AU steering committee yesterday, and I saw Ghana had included private sector, but then have moved back on that. And the reason they moved back on that is because there was seepage of patients. Or when people are tested, they were positive, and they were tested in the private sector, the protocol wasn't very clear in terms of what do we do with the positive ones. For government, it's immediate, either home-based quarantine or facility, government facility. When they're tested in private sector, what happens next? So those protocols are part of the enabling environment that we need to think about because they enable the collaboration. The next one is capital. We've seen private sector coming in to put in oxygen, for example, where government cannot mobilize resources to put oxygen tanks, oxygen plants. We are seeing private sector coming to say, we will do the oxygen plant, the oxygen bank tank. You purchase the oxygen, but we'll provide the capital financing for making sure oxygen is available. And this is also reflected in earlier collaboration with private sector, like in many countries, the managed equipment service, which has been done, where private sector provided capital for the equipment and the government then pays for recurrent expenditure. The next thing is manufacturing and R&D. If we do not have private sector working with governments across the world, we will not have a vaccine. That is as simple as that. We are not going to have a vaccine for COVID. Therefore, we are seeing collaboration. We are seeing most of the vaccines that are now candidates is private sector working with the public sector. The other area is technology and innovation. Ourselves as an organization, we have used technology for training community health workers, for example, for collecting data, for training other health workers. So we have something, for example, I'd like to reflect on LEAP, which is a phone-based training platform which uses text and voice, doesn't require internet. And we have seen governments, because of the requirements for social distancing, and now they need to train health workers, and they need to train community health workers, the need for technology has never been bigger. So whereas we spent our time trying to convince governments to adopt some of these technologies like LEAP and one we call JIBU and others, suddenly the demand, for once I had a letter from a Minister of Health in Ethiopia saying Ethiopia has adopted LEAP as the technology for training community health workers. I popped champagne. I've never seen that, because most of the time we spent ourselves is, convincing government this should really work. Why don't you adopt it? But suddenly COVID has come and there is urgency to adopt technology. So we've seen COVID also a silver lining, accelerating government need to adopt technology. And there are examples I can give of difficulty, and I think I'll talk about that in enabling environment. And the final one I would like to reflect on is where government not only contracting services for private sector, which we have seen happening with UHC, but also governments contracting private sector to run public health services. Kenya, we are attempting to do that with one of the counties, but in Togo, it has been a successful experiment where the government actually tenders for contracts to private sector to manage public hospitals. And now I saw more recently saying they are so successful that the government is now asking the contracted agencies to give bonuses to the workers in the public hospital because they are saving money at the end of the year. So these are things that we need to reflect on. I don't know whether I have time to give you the enabling environment or you want me to address that later, Desta. As a moderator, you'll tell me whether I shut up or you'll come back to me to do the enabling environment.
Oh, I would never tell you to shut up. That would be a suicide on my end.
So let me continue then, if you don't mind, so that I finish this issue.
Continue.
So I want to just highlight on very key overarching principles that we must think about when we are thinking about these areas of collaboration of private sector. And I'll just name them. I'll try not to explain them. The first one is equity. The balance between the profit logic and the social logic is the reason why there is such erosion of trust. And obviously we know that there are incidences where trust has failed and governments have beat their fingers. But we also know there have been many instances where there has been success. But that balance between profit motive and social logic must be taken into consideration as we are looking at the policy environment. Secondly is accountability. Who holds who accountable? Governments, will say our people hold us accountable. Never mind, in many of our countries, That accountability has not worked because civil society is not properly capacitated. But if governments can say, our people will hold us accountable, the parliament will hold us accountable, who holds private sector when we are working together with government accountable? So an accountability framework must be built up together with transparency. Third is that all these things must be based on evidence, that we must also bring in evidence in terms of what works and make sure whatever works is based on national health strategies, not just an exciting innovation, that it is actually based on the national health strategies. The other thing I would like to mention is that it must be based on common values, that the government must also look at what are the values or the aspirations of the private sector as much as what are our aspirations. And those shared values that is a sweet spot that actually must drive the policies. And finally, the issue of mutual learning and ensuring that actually whatever works is shared. That's one area I found a weakness. What works? What doesn't work? How do we share? And I'm glad that we are having this conversation now. And that is part of the role of the UHC 2030 private sector constituency. So to enable this to happen, we must have government commitment, government leadership must be at the center. The private sector cannot do it without government leadership. Second, there must be regulatory and legislative structures, so that to make sure that everyone knows what boundaries we are working in. The third thing is that we must provide equitable financing, because that's what is going to make private sector successful in healthcare. If we are going to not to have sustainable, equitable financing, then the private sector will tend to always gravitate to secondary and tertiary care, whereas the need is in primary healthcare, where there is not enough money for private sector to achieve its objectives. So we must, equitable financing, which is UHC, is actually a foundational element of success in PPPs. The next thing is we have to build capacity of government to engage with private sector. Governments don't know what to do when it comes to private sector. So capacity to engage with private sector must be built, including procurement capacity. Right now, the public financial management provides only for procurement of general commodities, where you tender. If you go to a government to sell innovation, they don't know what to do with it. They have privately initiated investment proposals, which are complex, they require cabinet approval. So whereas the government agrees that's good innovation, the process to procure the good innovation and private sector innovation does not exist, except in emergencies like this. We've seen government say we want to order the kit from so-and-so because it's an emergency, and they are invoking the Public Health Act. In normal circumstances, it's difficult. And finally, sharing knowledge on what works is critical, not only within our space, but also with government, because then it would help colleagues like my friend, Honorable Kiprop Mishra, to then take this to Parliament with evidence, legislate, and it's easier to adopt. Thank you very much, and back to you, Desta.
Thank you very much, Githinji. And actually, you have raised so many different issues. We could probably have many different webinars on each one of these issues that you've raised. I think really very much appreciated. And just picking up on the discussion or how government is really rapidly engaging the private sector. You talked about the government creating an enabling environment, etc. I want to actually come to our speaker, Dr. Paul. I hope you're with us now, Dr. Vinod Paul. We introduced you earlier, and I hope you're with us. If you are there, if you can unmute your phone, that would be great. Dr. Paul, are you with us? Oh, there you are. Fantastic.
From Delhi.
Welcome, Dr. Paul. We introduced you earlier, and I'm sorry you came in just a little bit late. So our listeners know whom you are, and we are very much appreciative that you are able to join us. And I hope you heard a little bit about what Githinji spoke about, and also earlier Dr. Peterson mentioned. And I think that Dr. Paul, you serve as the chair of the committee which issued the report on the containment strategy for COVID and for Delhi. And part of that was really around, working with private sector. And as you revise the demarcation of the various districts in Delhi, you also were involved in linking every district with a hospital which raised many different issues around capping hospital rates and engaging with private insurance, etc. Dr. Paul, perhaps you can just talk to us about this experience that you had in terms of capacity building or bridge building partnership with private sector.
Thank you very much. I think what is going on in Delhi seems to be very well known to you and to other colleagues, although Delhi picked up on the scene only recently. But I would also highlight the fact that, yes, I'm part of the national team for COVID response, and the organization that I represent is the Apex think tank, which is actually chaired by the Honorable Prime Minister himself. So let me say, I'll come to COVID in one moment, but let me say that the Government of India has involved the private sector in healthcare in a very systematic manner, more so in the last 3 to 4 years. And here I refer to our secondary and tertiary care universal health coverage program that goes by the name of Ayushman Bharat, which has two components. One is universal primary health care, which is driven by the state, funded by the state, the union and the center, union and the state governments together. And that's a space for public sector, that's government. We recognize that primary care is the business of the government. But the other limb of Ayushman Bharat is PMJ, which is ensuring secondary and tertiary health care for almost half of India's population. Almost half of India's population. It's 750 million population, half of India's population. It is a scheme which is again in partnership with the state governments. The center covers part of the expense and the rest is borne by the state. And when we implement that scheme for the lowest quintiles of our population, the services are provided both by the government hospitals as well as the private hospital. And they work on the same terms and same quality assurance and accountability framework. So there are about 22,000 hospitals and about 11,000 of them are private hospitals. So we have learned to work with the private sector as never before. This scheme is thriving. It is still about 18 months old. We have covered more than 10 million beneficiaries who receive treatment in this scheme already. And we hope that we will expand this mission to other people. The point that I'm making is that perhaps this is the biggest PPP, of course, in India, but surely it may also be a very big PPP exercise in the world, where such a large set of beneficiaries are accessing services. The beneficiary can choose to go to hospital, a public hospital, for appendectomy or for chest pain, or for intensive care, or for cancer therapy, or choose to go to the private sector hospital, and the charges are same, the expectations are the same, and there are quality parameters built into it. I may also add that we also have a very large private sector presence in medical education. I chair the Medical Council of India, and I can assure you that half of our medical colleges are in the private sector. So the whole lot of medical education also is in the private sector. There are issues about the quality, both in the public and the private, but the fact is that we live in synergy with each other and contributing toward the medical education as well as nursing education. I also wish to emphasize to you that freestanding private hospitals are also imparting a very major component of our postgraduate program outside the medical colleges, and these are typically thriving large private medical colleges. So private sector has been embedded into mainstream of India's healthcare system and health professional education system, and it's thriving well. And the advancements that the PMJ, as I said, is only about, it's September 18. So it's not been for long, and we are moving forward with this nationally. Therefore, India's universal health coverage vision is thriving on public-private partnership in the space of secondary and tertiary care services. Primary care, state, government largely, there can be contracting in, but then for secondary and tertiary care, and even more so for tertiary care, we would depend on our very valuable, very effective and high quality private health sector as a matter of routine. Let me now come to COVID situation. And here you did refer to the Delhi situation, which we are bringing under control very rapidly. I'm proud to say that for COVID, our private sector rose to the occasion in the space of testing, very rapidly ramping up their capabilities. States have their own arrangements of how the payment should be made. We can talk about, whether they are generous or they are not so generous, but the fact remains that we use the private sector capacity hugely for our response to COVID. And we are very happy about the standards that they maintain and the services that they are provided. Also, we depend on the hospital bed capacity in the private sector over and above the coverage that I was referring to as part of our national schemes. We have been requisitioning beds in the private sector through an enabling provision in the law, but in partnership with the private sector. We call them as COVID hospital, COVID beds, COVID tower, as the case may be. And there again, state governments, for our country, health is a state subject. State governments are approaching and the private sector and are engaging them on a daily basis to provide enough of our capacity for COVID should the surge happen, which is well beyond the limits of the public sector. So the partnership for COVID between the public and the private is thriving well and gelling well and moving forward very effectively. It's a joint response. I really consider that for practical purposes in India, it is one health system in which public and private in the secondary and tertiary space work together. And over this period of time, the relationship of trust and working together has emerged very well. I'm also happy to say that in the private sector, the involvement of our private companies for vaccine development, pharmaceuticals, and diagnostics is a very notable achievement. As you know, India is seen as a pharmacy of the world. We look forward to being the vaccine pharmacy for COVID in coming times. We have at least 5 to 6 to 7 very big companies that are in arrangement with global players in vaccine. We believe wherever the vaccines are discovered or a vaccine is discovered, much of the production or the bulk production for the world would take place in India. And very effectively working as one government, as across our scientific organizations, to make sure that we enable the path for these companies to be able to respond to this emerging need, emerging necessity, and emerging priority. So we are preparing, building our capacity, and the government is going out of the way to ensure that stockpiling could take place. We are prepared as soon as vaccines are available. They could be manufactured, and also preparing vaccine trial sites in a very effective manner. The same thing applies to our COVID diagnostic capacity. I'm pleased to tell you there are at least 20 companies which till 12 weeks ago were producing no test for COVID, or 12 weeks to 14 weeks ago. And now they're producing potentially 500,000 test capacity per day is being produced indigenously in the country. And again, here we are working together, working with a science enterprise and moving forward. Likewise for drugs. As you know, remdesivir has been given a voluntary license to 7 of our companies. And we consider that to be part of a public-private partnership. And I assure you that on a daily basis, we have connections and connectivities and working together to make sure that this huge response, which goes beyond the need of India, is cemented and is harnessed. I also would like to make a point with regard to the role of non-profit private sector in two ways. One, in ensuring the right behaviors in the COVID era, to be partners for social behavioral change. And here I am expecting our non-profit communities to do more. I think there's so much more that should be done. I think we have really not harnessed the full potential of our non-profit sector in playing a role in rural areas, in small towns and large towns. Yes, but they are there and they are partners with us. At the same time, we are also depending on the non-profit as well as profit private sector for community mobilization, taking their help in setting up, these voluntary mega hospitals, their investment into drug discovery, their investment into contact tracing, investment into training of our health professionals. They are running telemedicine courses and hell of a lot more. So in summary, my take that I bring to you is the following: that in India, COVID response as well as universal health coverage as a broad mission will not be achieved without the fullest participation of the private sector. We have built stronger bridges than ever. We have a much bigger level of trust as of now, and our mechanisms how to work with each other are stronger than ever. Yes, you are right. We do fight over rates, as you would when you are on the other side. This would happen, but we have learned to work together. And as I said, the success of the Pradhan Mantri Jan Arogya Yojana, where more than 10 million people have received treatment, demonstrates the fact that you can work together on scale and provide affordable care to the people of India. I'll stop there. I'll be happy to take questions to
Thank
add
you so
this,
much.
but thank you very much for the opportunity.
Thank you so much, Dr. Paul. You've raised quite a number of very interesting things that we can certainly look at as we explore where the research needs are. And I know we are running a bit over time, but I think the discussion is good, and I'm going to ask my colleagues to allow us to just finish this session off well. So I would like to invite Dr. Iyer Jay. I know that you are, Jay, are you there? If you can unmute yourself.
Yep.
You're currently leading, fantastic, good to see you, long time. I know you're currently leading the ATM and in this role, you're really working and have been very vocal on the role of pharma and the impact of COVID on prioritization and development of solutions. So if we can just ask you, and I know that you have been heard to say that we have a shared responsibility to ensure that the most vulnerable among us are not left behind. So if you can just briefly share with us, how can the large multinationals in pharma contribute to the government's efforts to expand access to medicine? And I know Dr. Paul earlier talked about India's role in drug manufacturing. And so maybe you could just speak briefly on that.
Sure. Thanks again for inviting me to this discussion. So I think I'll refer to the COVID epidemic. In a way, the COVID epidemic makes people realize that the most vulnerable people are going to be hit the hardest. And the way we measure success should be in achieving global access. It shouldn't be in achieving access in only one or two key countries. So, and I think people have to remind of the fact that 80% of the global population currently live in low and middle income countries. So there's been a lot of efforts now among the research-based pharmaceutical companies, among the generic medicine manufacturers in looking at how they can be more prepared for pandemics. Years ago when we first started evaluating how the industry has been responding to pandemic preparedness, investing in R&D, investing in manufacturing capacity, we saw quite a dismal picture. And COVID has definitely opened up more companies to think about how can they contribute to this space, and also keep some of their existing commitments running in the same period of time in that sense. So at the same time, you have to realize that there's only very few companies in the world that currently still are in the infectious disease market and still innovating. And there's still a lot of innovation in the biotech industry. So there's no clear pathway of how we're going to commercialize, manufacture in a large scale. And I think that's one thing that COVID has done, is brought a lot of companies together, brought a lot of stakeholders, leverage the discussion so that we're talking more about manufacturing capacity globally. How are we going to ensure that around the world everyone's going to receive access when the possible vaccine is actually available at the end of it. There's two things to remind ourselves on this. One is the typical pathway at which vaccines are brought to the world has been something that we've all been investing for a long time via Gavi and outside Gavi via lots of procurement systems that governments have been investing in. And I think it's an important thing to look at what COVID has been doing so far is making us remember that a lot of the areas where we've had the most progress, where we've tangibly seen progress in access to healthcare kind of outcomes, patient numbers being increased, is heavily dependent on donor support globally. And that's something which I think we have to realize, that when COVID comes along, the donor support is obviously threatened, and other areas may get affected. We've also seen threats to progress. We recently published threats to progress for access in pediatric development in HIV, malaria, and TB treatment. And we've seen basically that a lot of the newer products that are being developed for pediatric formulations have been severely delayed, just because the regulatory agencies are flooded with a lot of different regulatory challenges associated with it. But there are also delays in the sense of collecting adequate data when it comes to clinical studies, when you need to recruit patients into studies in that sense. So there are severe delays. There's also severe effects in terms of certain governments wondering how can they divide their resources between existing commitments that they've already made in health versus what's happening with COVID, and how do you divide the cash in equally. And as Stefan already mentioned, there have been visible effects in terms of how much COVID and the issues of health systems not all being ready in some of the most vulnerable countries in the world have affected our ability to bring care. With 40 million people missing their polio drops in Pakistan after the cancellation of the nationwide vaccination campaign, polio making a comeback in Nigeria, children in the Democratic Republic of Congo haven't been vaccinated against measles this year. In South Africa, millions who live with tuberculosis and HIV treatment centers have been converted into COVID-19 wards. So balancing existing treatments and what COVID is facing has thrown up, I think, is a real big issue. And there are also two issues that we've seen that kind of tell you a bit more about what the future of this post-COVID world we're going to live in needs to be based on, and the kind of partnerships that need to be sustained, I would say. One is on supply disruptions of essential medicines. I think many of us would appreciate the fact that 60% of the world's active pharmaceutical ingredients are manufactured in China and India. And whenever you have some level of China shutdown and India's limits on medicine exports, that really frightened a lot of governments around the world, who then realized their own limitations in accessing medicines for their own population. And there's several countries around the world who only import medicines from outside, so they don't actually have a local source available. And of course, any level of nationalism that comes forward to say, look, let's secure our people's needs first and limit exports in that sense has not really helped the situation a bit. So we've had some severe supply disruptions that we've been monitoring, and we've also seen some companies saying, okay, look, we can ramp up our capacity for supply so that the disruptions are not going to be as difficult to manage in the most troubling months. But it tells you again the difference between a companies that have that long-term supply planning in place so that they've got reserve stocks available versus those that don't actually have the reserve stocks and are dependent on procurement behavior and kind of ad hoc requests in that sense. So the other thing I think that is important to look at is when you do have a medicine or a vaccine directly targeting COVID, or a pathway for new drugs anyway that are being developed, as Gitinji said, there's always a problem in the sense that there's actually no system in which to procure these particular medicines. And we do need, in several areas, in certain countries that does exist, but I think in several countries that is an issue. So a lot of the times we've been getting involved mostly in discussions about what does fair allocation principles mean? Does a company have to wait until a market is actually available, or have to wait until donor support is available to take the risks away from the market? How do you put affordability principles in place when you're dealing with countries that may fall outside of the eligibility of some of the systems that have been developed through donor support, but still have a lot of people who are living under the poverty line in those countries itself. And I think the last thing that we've been involved in, which I think is starting to get a good change in the right direction, is for years, when I first started this work in the Access to Medicine Foundation, the investment climate used to look quite different. Investors would look at us and say, sure, but we're interested in the markets that are more lucrative than the markets around the world. But I think what investors noticed in the last few months is that they've started losing money in all aspects of their investments, in all sectors, due to a virus, due to pandemic preparedness that used to be far away and used to be considered as something that one would not necessarily invest in. So we've been working with over 100 investors. We get daily requests coming from investors now on what do investments look like, how can they engage with the industry, what should they look out for when it comes to good behavior, good practice when it comes to the pharmaceutical industry's response in it. So, and at the end of it, we've all committed to supporting universal health coverage. So every pharmaceutical company, basically, the main system that they should be keeping in mind is engaging in existing priorities, finding a way to keep commitments and timelines in place, because there are partnerships that are ongoing that we've all invested a lot of time and effort and hard-earned money in. And at the end of it, ensure that the products that they are manufacturing are affordable and broadly accessible in countries, especially the countries that have the highest burden of disease. They should not, people living in the countries that have a highest burden of disease should not have to wait at all. Yeah. So, having that broad access, I think, is important, and trying to do this in a transparent, responsible way, so that they're not putting further pressure on health systems that are already compromised in this state. And we're starting to see that effect. We're monitoring this area quite closely. As part of the Access to Medicine Index, we'll be looking at some of the responses that come forward. Our hope is that we'll see a lot more interventions, also looking at low and middle income countries that benefit lots of people abroad.
Thank you so much, Jay. That's quite a lot of information, and I know for us this is such a great opportunity to learn from all of you who have been very successful in these partnerships, public-private partnerships, and will be hopefully that you have already set the tone and you have set the framework for us to begin and continue our discussions. As you know, this is a closed group discussion for us, so we really appreciate all of your contributions. And I want to, Honorable Dr. Mishra Kiprop, you are a member of parliament in Kenya, and I know that we have your fellow parliamentarians are also on this virtual meeting, and you all serve at the intersection of where the people meet the policy, and where the regulations and the legislations impact some of these critical partnerships that were mentioned earlier by Gitinji, by Jay, by Dr. Vinod. So within your role and from what you've heard, I would really welcome, we would welcome if you would just make a few observations as we wrap up our panel briefing. Just if I can give you 2 or 3 minutes. I know, team, we are running behind, but Dr. Kiprop, perhaps you can just do a brief closing for us with your observations from the perspective of being a member of parliament.
Thank you very much. Good afternoon again, everybody. I hope you are hearing. Yeah.
Yes.
Don't forget, I'm a politician and cannot restrict a politician, as you know, because once you have the microphone, we don't end. But I'll try to shortcut. And my senior, Dr. Gitinji, was very elaborative and great. but I'll try to match it. Let me tell you, in our lifetime, all of us here, we have witnessed two things: the electronic gadgets like cell phone, internet, email, and another is COVID-19. You remember before electronic gadget era, our working lifespan was maybe 20 to 25 years. But today, with the electronic gadgets, some of us working 80 years in 60 years lifetime or 100 years lifetime. But today, COVID-19 has just taught also a great thing called lockdown, no work for certain period. However, we have to learn a lot in this completely two separate occasions. However, I will tell you today, COVID-19 pre-era and post-era, as far as health is concerned, will be two different era. In Kenya, I have 3 lives in 20 years, academics, business, and politics. What I saw that we are going to start universal health coverage, which is an initiative to health for all, rich and poor, anybody, with 4 things: accessibility, availability, affordability, and acceptability. Now, this COVID-19 is also teaching us the 5 pillars of health care system. One is healthcare financing. Number 2 is the leadership and governance. Number 3, the human resource, and which we call health education. And number 4 is called, we can say, the equipment, infrastructure, commodities, etc., etc. The last one is called data, technology, and research. We have to focus on these 5 points today so that it will enable us, both private and public sector, to work together to battle the new era is coming. Let me tell you, COVID-19 or SARS-2 or whatever, Corona, whatever you say, very little is understood today. But this disease, this invisible virus has made us 2 things. It gave 2 messages. One, it brought the world to one platform. And number 2, it united the world. As far as healthcare financing is concerned, I think the time is coming. We don't know how many viruses will come, but the countries will cut down their defense budget and transfer the budget from defense or security to the health security. Now, public-private partnership. Public-private partnership is there always, but it was never regularized. There is no proper agenda or proper understanding or MOU or terms and conditions are never made. It's a marriage. It's a marriage. Public-private partnership is a marriage. Without proper understanding and proper collaborative ideas, we cannot make it successful. We should not be liabilities to each other. It should be an asset. We should be asset to each other. We should know what is our responsibility. What is public sector? What is private sector? We have to understand the definition. As I said, that we have to make an international meeting, the whole world, to make a proper marriage between public-private partnership in health for all the countries in the world. And then from there, we can go for specific countries as far as local requirements and SWOT analysis is concerned in both sectors. I'll tell you, China, India, America, Kenya, Netherlands are 2 countries. They are public and private sector, they work differently. So we can go for that. The next one is that there should be proper understanding without interference. There should be proper accountability, audit, both in without a biased way. Then only it can be successful. Health is not only hospital. Health is not only treatment. Health is not only healing. Health is also preventive. COVID has taught us preventive aspect of medicine. You know, today, after COVID, it used to be 10% people used to go think about preventive aspect. But now 90% people are now thinking in the world how to go for preventive aspect. In our health education, preventive aspect of medicine is not existing. We just say, oh yeah, preventive medicine. There is no treatment. So they don't. Now we will think about the curriculum of health, how strong and how important it is. Now we'll know. We'll do a lot of research about preventive aspect, about the unseen, forthcoming, forecasted diseases. Now, apart from that, health facility is not only about the treatment, as I told you, but health manufacturing. Health manufacturing is another aspect which we require both public and private sector very strongly. How many countries in this world are, and what is the percentage of health manufacturing by the public sector? I think 99% things are medical equipments, medical furnitures, pharmaceuticals, disposables, non-pharmas, all are by private sector. So there we have to have proper understanding between public and private sector. Health education, as Dr. Paul said, in India, and I am from India, I came to Africa in '97, but now I'm a real African. But I'll tell you, Dr. Paul is right, 50% of education in India is private sector. So we have to collaborate. We cannot, air hostess cannot replace a pilot in the aeroplane. So a doctor is required, we have to need a doctor, we need a paramedics, we need nursing staff in a proper way. In Africa, I tell you, in African 54 countries, the capital cities are different story than non-capital cities in Africa. We have no HR, we have MRIs, we have CT scans in the public sector, as far as in my country is concerned, but we don't have HR. So all these things we have to address properly and nicely so that it will be a success story. But post-COVID, the blessing in disguise for all of us.
Thank you, Dr. Kiprop. We appreciate it, and we know that certainly from your side, you'll also support on regulatory and legislature